Managing a headache presentation in primary care in 10 minutes is not easy, so what I'm hoping to do in the following slides is to help you navigate the challenges of the 10-minute headache consultation. And I want to look at two cases. This is the first of two videos, and this will deal with a new headache where the history is short and it's fairly uncomplicated. The second video will then deal with a more complex, challenging case where there is chronic headache with complex multimorbidity, and these two approaches are very different. So I'm going to offer some insights from the perspective of primary care within the context of anything between 1 and 3 10-minute consultations. You may need more than one 10-minute consultation to sort out the problem. So this is the problem we're looking at in this series of slides, a simple new headache presentation. And our strategy here is to make a diagnosis, offer a simple explanation, and treat appropriately. And our starting point for a diagnosis is the International Headache Society classification of headache. Headache first formally classified in 1988. We're now on our third classification revision. And headache is divided into two types, primary and secondary. Secondary is the much rarer type of headache, less than 5% of what we'll see in primary care. This is headache where there is an underlying pathology that is readily identifiable, and this is subdivided into a number of subsections. I'm not going to go into them in any detail. If you want to look at the International Headache Society criteria, it's all online. It might be worth just dipping into, but the main focus of attention in primary care is primary headache. This is headache where we recognize a pattern and we're not too sure what the underlying mechanism is. It's something at a cellular level, and we're beginning to unpack these mechanisms, but there's no clear answer as yet. So this is a pattern. Primary headaches are diagnosed on the basis of their pattern. So the International Headache Society classification book runs to over 200 pages. So how do we manage this? Well, the first step, I'm going to offer you some simple steps. First step is don't panic, because we're going to move to step 2 quite quickly, which is to apply our Bayesian statistics, our prior probabilities. And here, from the perspective of primary care, is what our likely probability of this headache being is. And you can see by far the most frequent cause of headache presentation to primary care is going to be migraine. And in fact, migraine is by far the most frequent presentation in all clinical settings, casualty, neurology, and primary care. Followed by cluster headache, and then the important secondary headaches, of which temporal arteritis is probably the most important one for us. We're always concerned about the underlying possibility of a tumour. The actual percentage is 0.09%, which is just under 1 in 1,000. So that gives you a feel of what sort of probabilities you are dealing with. I think humans are not algorithmic creatures. We're heuristic creatures. We like rules of thumb. So I think based on that probability model, we can start with a very simple rule of thumb. And if someone comes in under 50 with a headache, a reasonable place to start would be by asking yourself, why is this not migraine? If they are over 50, although migraine can present over 50, it's relatively rare, but it can happen. I think a more appropriate question to ask yourself is, why is this not temporal arteritis? Next step is to take a history. Headache is all in the history. It's very rare that examination will change. It might focus a diagnosis, but it's very rare that it will change your actual management. So the history is all important. And I'm not going to go into how to take a pain history in any detail. I'm sure you'll be all up to speed with this, but these are 3 questions I think are particularly important for the headache presentation. I'm always after a history of problematic headache in the family. If there is a history of problematic headache, you're almost certainly going to be looking at a migraine phenotype in front of you. And often they won't know that their parents had migraine, It would often be mother would be having her sick days lying in bed upstairs, and not always a diagnosis of migraine will be made. So if there's a history of a problematic migraine, then this raises your suspicion of a migraine presentation. How long the pain lasts for is an important one to help us differentiate between our headaches and, probably more importantly, associated features. Migraine is a feature-full headache. It'll be light, sound, movement, touch, sensitivity, nausea. Cluster headache has associated autonomic features. And the other key question is to ask them what they do when they get a headache. Someone with tension type headache will just get on with it, probably take a paracetamol. Someone with migraine will want to lie quietly, pull the curtains, turn the telly down. Someone with cluster headache will pace the room, they will be agitated. So I think the action of the patient when they get a headache is a key question to help you in the history. Having taken a history, you move on to a basic examination, and I think if they're over 50, I think it's almost mandatory to check their inflammatory markers to exclude a temporal arteritis. So I think 2 examinations at the first appointment, that's all you need to do. You could certainly check their blood pressure, although most people will know what their blood pressure is. It's very rare that you'll pick up a malignant hypertension, but I think it's just good practice, and I think it reassures the patient if you check their blood pressure. The relationship between mild and moderate blood pressure and headache is not clear, but the most important and mandatory examination is fundoscopy. Now, many GPs are not happy about fundoscopy. We're not looking for nuances of changes around the disc here. We're looking for bog standard barn door papilledema, which is actually quite rare, but I think you need to look for it. And if you're not sure, then ask the patient to go and visit the optician and get their eyes looked at properly. Opticians can now give very accurate assessments of the retinal function. So having done that, you're now in a position to move to step 5 and choose 2 buttons to press. The red button, do something right now, or the orange button, do something fairly soon. So when are we going to press the red button? Well, clearly if someone has papilledema, you're going to want to get on top of that pretty quickly. And this is what you may, in the extreme situation, be looking at. Papilledema can be caused by some form of obstruction in the circulation of CSF, usually caused by a lump in the brain, but not uncommon these days, particularly as the population is becoming more and more overweight, is this condition called idiopathic intracranial hypertension. We're not sure whether the raised pressure of CSF is due to overproduction or under-reabsorption, but these are usually obese females who present with headache. They can present with any type of phenotype. They can have pulsatile tinnitus and visual disturbances. And with all papilledema, you're after saving sight here. So I think if you see this presentation, then that's also going to be a red button. Our second red button is a thunderclap headache. This is a headache that rises to its maximum crescendo in 1 minute. It's a headache like they've never had before. They often feel they've been hit over the head with a baseball bat, and these people have to go into hospital straight away. What's slightly more problematic if they come in because they can't get an appointment to see you for 3 weeks, they come in and say, I had a thunderclap headache 3 weeks ago. No, they'll probably need to be investigated straight away. Probably the best thing is just to have a chat with the neurologist on call or the physician on call, who will probably want to see them. But what happens if they've had a thunderclap headache a month ago? It gets a little bit more problematic, but probably best to have a chat with someone just to cover yourself. But if you see them within a reasonable time of having had a thunderclap headache, it's a red button. And here are some of the differential diagnoses of thunderclap headache. Indeed, migraine is not on that list. Migraine is probably one of the most common causes of thunderclap headache. So you don't need to worry about the diagnosis at this stage. They just need to go in. However, there is a subset of step 5, and that is that sometimes you're going to have to address the inadequate management of headache in casualty. Headache is the bane of casualty doctors' lives, and all they will be keen to do is exclude a serious pathology and then send them back to you. I'm sure this isn't true right across the country, but I think this is a common experience. So you might be presented with someone who's had a normal CT scan, possibly a normal LP, and told to come back and see you, and you're now not clear what you have to do. Perhaps you might want to refer them to neurology, but there's going to be a year-long waiting list. I think at this stage it might be worth having one or two other things in the back of your mind and some other questions up your sleeve. So let's unpack those presentations in a little bit more detail. So the first three problems, hopefully they will be excluded with a CT scan. Hopefully pituitary apoplexy, that is a hemorrhage into the pituitary gland, or venous sinus thrombosis will have been thought about in casualty, and they would have excluded those things. If they have pituitary apoplexy, then they will be systemic features. With venous sinus thrombosis, this can present in a number of ways, but there are often thrombophilic tendencies, of which pregnancy and cancer are probably the two most common. So you still need to have your eye open for those, although hopefully they will be excluded, but they will not necessarily show up in a normal CT scan. Then there are the things that A&E probably won't think of. Carotid artery dissection, spontaneous intracranial hypotension, a sudden rupture of a diverticular in the dura, acute cervical instability. And the key question here is, do you have lax joints? We're asking for this now all the time, and of course when you ask for it you see it more. A lot of people have Ehlers-Danlos spectrum, and if you have poor collagen, poor connective tissue support, you are vulnerable to a number of problems, of which headache can be one of them. So those are some of the problems that might arise from poor supportive connective tissue. So you could be on the lookout for lax joints. And then finally, an interesting problem, which is reversible cerebral vasoconstriction syndrome. Probably A&E won't think of this. And I think the two key questions here is, have you ever had a sex headache? Because the majority of sex headaches are probably caused by this problem. And you need to be on the lookout for vasoconstrictive drugs, of which the two most common ones are SSRIs, or recreational drugs such as cannabis or cocaine. I had an interesting patient in recently who had been seen in casualty with a thunderclap headache, sent home because they were excluded as subarachnoid. Hadn't really taken any sort of history at all, and he'd been having a number of sex headaches in the past. His GP had just increased his SSRI, and he was a fairly heavy user of cannabis, so he fitted the picture pretty well. So what is reversible cerebral vasoconstriction syndrome? We're not 100% sure what is going on, but you can see what happens, and you can only diagnose this with an angiogram, and they can in fact stroke. The problem is that we don't understand the pathogenesis, because constriction is not immediate with the pain, and the pain can last up to 3 months or so. So the situation as far as pathology is not entirely clear, but it is important to have this diagnosis in the back of your mind. The final red button, I think probably you need to do something right now about someone over 50 who presents with headache, even if it's only checking their inflammatory markers, because you can't miss temporal arteritis. If you have a high level of suspicion of temporal arteritis, then depending on local protocols, I think they need treatment, or certainly diagnostic confirmation pretty quickly. So I think I'm just going to say follow local protocols, because things are shifting as more and more people are now using ultrasound diagnosis for this problem. There are other red buttons we have to have in the back of our mind. Acute glaucoma can present as headache, malignant hypertension, encephalomeningitis. Hopefully you're going to not miss that. But always bear in mind that there are still a number of fatalities a year from carbon monoxide poisoning, which can present with headache. So those are our red buttons. What about our orange buttons? Do something soon. I think there are two things that fall into this category. First of all, if you're concerned that there is an underlying tumour, and I'm going to put cluster headache into this category as well. There are lots of frameworks for supporting you as to who to image. We can be reassured that only 10% of tumours will present with headache only. If they present with headache, of which 50% of tumours do, the majority will have an other feature, sign or symptom, which will alert you to the fact that there is some other problem. And I'd like to talk about red flags and orange flags. So these red flags are where there is probably a risk of over 1% of an underlying tumour and you need to image them. Clearly headache with abnormal neurological signs or symptoms. New seizure, that's about a 2% chance. Headache triggered by exercise, that's about a 10% chance of having an underlying tumour. Not headache exacerbated by exercise. Lots of headaches will be exacerbated by headaches, and in fact migraine can be triggered by exercise. But I think that's something you need to look into. And a recent history of cancer elsewhere in case we're looking at secondary deposits here. Orange flags, these are where there's an underlying risk of a tumour of between 0.1 and 1%. These we can watch closely or not unreasonably image. I think one of the problems is we are becoming more and more risk averse in this litigious environment, and we're tending to image, particularly in secondary care, more than we really need to. But these are some of the features that you would be concerned about. Anything that raises your intracranial pressure, anything that shifts in character significantly. Now this is a tricky one because migraine waxes and wanes, it comes and goes, it can change its character. So you really need to be experienced in headache before you know what a significant shift is. Lots of headaches awake from sleep. Cluster and migraine will awake from sleep. We've talked about new headaches over 50. You've got about 2 or 3 times the chance of having an underlying tumour, the risk going up as you get older. And then there are these subtle changes, memory loss, personality change, which may reflect a frontal lobe tumour. So you need to have a very low level of suspicion in these things to trigger further investigation. I'm not going to discuss the pros and cons of MRI or CT, but MRI is the gold standard of choice, but in many areas CT will be available to GPs, so again follow local protocols. The other orange button is cluster headache. I think cluster headache is arguably the most painful condition known to medicine. I particularly like this X-ray as a teaching tool. This shows shotgun pellets. Someone has taken a shotgun to the head. Cluster headache, suicide headache. And I think people with cluster headache shouldn't be languishing on neurology waiting lists. Something needs to get sorted pretty quickly with these people. So you're happy you don't have to press a red button. You're happy you don't have to press an orange button. What's the strategy? Well, the strategy is to play for time, looking for a pattern to emerge. So you tell them, you reassure them, this will be the end of consultation 1. Hopefully you'll be able to do what I've alluded in those slides within 10 minutes, although that might be a bit of a stretch. You reassure them you don't think there's anything serious going on. And your delaying tactic is to ask them to keep a diary. Now, I don't find diaries particularly helpful, but they like to feel that they're doing something and you're paying attention to their problems. So you safety net them and ask them to go away and keep a diary and ask them to come back in 4 weeks' time. So we're now at step 7. 4 weeks later, a pattern has still not emerged. Still not sure what is going on with this headache. It's too early to do anything more specific unless there are any red flags. So delaying tactic number 2 comes into play. Now at this stage you will need to do a basic neurological examination, but your delaying tactic here is basic blood tests. it's very unlikely that they will show up anything. Blood tests don't really have any position or place in the management of headache. You may find an undiagnosed renal failure that's causing them headache, or the LFTs might be all over the place and they've got a secondary deposit from a primary somewhere. But blood tests are quite useful as a holding mechanism. And I think a key point here is don't do any other blood tests unless they are clinically indicated. So don't start thinking about anti-nuclear antibodies or antiphospholipid antibodies unless there is a clinical indication. Otherwise, you will come up with a false positive and find yourself down all sorts of rabbit holes. So no other blood tests except for your basic screen unless clinically indicated. So you reassure, I've examined you, there's certainly nothing serious going on. I think it would have shown if there was anything in the examination. You ask them to continue their diary, you check their bloods, and you see them again in 4 weeks, hoping that a pattern may have emerged by that time. This is a very good, quick 3-minute neurological examination by colleague Giles Elrington that you can find on YouTube, which you can use or abbreviate, but I think that's a very useful starting point for your neurological examination. So step 8, they come back. We're now 8 weeks from original presentation for our third 10-minute appointment. You're still not sure. What happens next? Well, you're going to repeat the neurological examination. At this stage, if you have access to imaging, you will discuss the pros and cons of imaging. I think NICE in their guidelines are very clear that you do not image for reassurance. One of the problems with imaging is the incidental abnormalities that you may find. I think 15% in primary care is a reasonable figure to use. As we get older, incidental findings become almost ubiquitous. White matter changes in the brain, which we're not quite sure of their underlying cause, can be very common. So I think a rule of thumb here is don't look inside the brain unless you have a really good reason to do so. And I think if you discuss this with the person in front of you, discuss with them the problems of incidental abnormalities and the facts that they can cause considerable anxiety, I think most people will be happy with that. But if you're still not sure about a diagnosis and they're still having headaches, I think at this stage you could certainly consider advice or referral. And although I may be biased, ideally to a general practitioner with a special interest in headache, I think this is where these sort of people should be going. And in the pathway, the ideal pathway, all referrals from general practice should be going to their general practitioner with an extended role colleagues. So hopefully that's given you some tips about how to survive the 10-minute headache consultation. More resources, there's lots of resources out there. The GP, we have quite a feisty group in the British Association for the Study of Headache of GPs with an extended role, and we're putting together, we're just beginning to populate this website now, headachegp.org.uk, with material for a wide range of people involved in the management of headache, ranging from commissioners to schools. And if anyone's interested in schools, particular area of interest of mine, that the support for schools is now complete. We've got a very good whole school project for headache in schools. But the one that you may be interested in is support for primary care practitioners, where this video sits. And by way of a brief advertisement, if you're really keen on headache, this is a little manual that fits into your pocket on headache that I edited with Peter Goadsby, now in its 2nd edition. And that's a really concise formulation of headache information that you will need for management if you are really interested in this area. So that's some pointers which I hope you may have found useful for the new headache presentation. In the second video, I'm going to look at the far more challenging but hugely rewarding presentation of someone who has chronic headache with complex multimorbidity.